So today we are focusing on question 9. This again a question that is based on toxicology. I have a 29-year-old woman who is brought in with drowsiness. It has stated that the GCS is around 6. If you want to go through this question slowly, what you need to do is you need to pause and then go through these and then come back to us so that we can discuss the answer. Right. So the patient has come with GCS of 6, and there has been a history of depression and chronic headache. The patient was on multiple drugs as well, and this and has been brought to us with an unconscious state. So that is the primary state that is alarming at the moment, and she has been found at a place where there has been some empty medication packs as well. So in this scenario, we are primarily having a pinch on to think that this patient might have had some sort of a poisoning, which might be an overdose of some sort of a drug. We are not sure yet, but it could be a overdosage and something to do with toxicology. So now we go through the question. Before going through the question, as a medical registrar, sometimes I have my own method of attending to such a scenario. One would be to in the quick word setting, what I do is I assess the pupil size. The pupils are very important. So in this case, even in this case, what I think is that the pupils are somewhat a great importance. And looking back at the question, I think that the pupil size that was given to you is 6 millimeters. So 6 millimeters, which means that now it is a dilated pupil, that you are looking at a dilated pupil. Now, if it is a dilated pupil, you have two possibilities. Either it is a sympathomimetic activity, which means sympathetics have been increased, or it could be a parasympathetic activity, a reduced parasympathetic activity. A reduced parasympathetic activity could be primarily the work of an anticholinergic. It could be a drug, it could be some sort of a plant toxin. If you can remember, one plant toxin that we know is datura, which has chemical properties that is similar to that of atropine, which can have somewhat anticholinergic activity on show nicotinic or muscarinic receptor antagonism, and thereby reducing the parasympathetics, which makes the pupils to be dilated. So datura, or else we are thinking about drugs that can cause the same thing. Again, atropine is one, or else it could be the other drugs that you come across are tricyclic antidepressants, which is TCA, and if not, there are certain other drugs as well that are not that clinically significant, but still they have their anticholinergic activity. For an example, a drug that is used in acute for urinary incontinence, such as oxybutynin, and also another important drug that is used in arrhythmia, such as not arrhythmia. There is another drug that is used in as an antipsychotic, such as quetiapine. So all of these has somewhat anticholinergic aspect. So it could be this, or else a sympathomimetic, such as usually it is the recreational drugs that are involved, which could be cocaine, it could be methamphetamine, or other recreational drugs that are usually used. So now, to differentiate whether it's a sympathomimetic or or an anticholinergic, you look at the other symptoms that the patient has. Now, if you look at the examination, now the first examination that I did was the pupils. Now I look at whether the patient is having how about the skin. So it could be, I usually have these three: skin, bowel, and the reflexes. So these are three things that I assess: skin, bowel sounds, and reflexes. Now, in this patient, the skin is dry and flushed. Dry and flushed. So, what to the sympathetic activity will lead to pseudomodal activity, which means now there is the production of sweat. Sweat production is primarily determined by the sympathomimetics or the sympathetic activity through pseudomotor mechanisms. In fact, it is driven by the cholinergics as well. It's a muscarinic receptor. It's a nicotinic receptor. So, since this patient has very dry and flushed skin, which is more now in favor of parasympathetic reduction or anticholinergism rather than that of sympathetism. So this is a dry and a flushed skin which can be used to identify parasympathetics from sympathetic activity, parasympathetic reduction from sympathetic overactivity, right? So now we know that this has something to do with parasympathetic, but to improve on the scenario and to eliminate some of the other pretenders or clinical mimics, some other modalities that you need to take into account would be neuromalignant syndrome, NMS, or serotonin syndrome with sympathetic activity. So another pretender. All of these three, neuromalignant syndrome, where you get this, usually you see that in Parkinsonism patients when there is abrupt withdrawal of anti-Parkinson medications such as levodopa, or else where you give these anti-dopaminergic drugs such as these antipsychotics, which will lead to exclusive rigidity and bradykinesia, Parkinson mimicking condition. So that is neuromalignant syndrome. Or else it could be serotonin syndrome. Serotonin syndrome is where you get when their patients are overdosed with antidepressants such as citalopram, citalopram, or sertraline. So these patients who are on these antidepressants have a suicidal urge, and then they take in overdosage of these drugs and come with serotonin syndrome. Again, the same presentation: low GCS and low GCS, and sometimes there are changes in the heart, cardiovascular system affected, the new CNS affected, and sometimes GI and the kidneys are affected as well. So in such circumstances, you need to identify whether it's actually an anticholinergic problem, a neuromalignant syndrome, or a serotonin syndrome, or an increased sympathetic activity. So these are the three types. So in the skin manifestations are like this. When it comes to the neuromalignant syndrome, it's because of the loss of dopamine, the skin, and serotonin syndrome, as well as in the sympathetic activity. All of these will show a diaphoretic skin, which means the skin is exclusively sweaty, unlike that of the anticholinergic mechanism, where you get a dry and a flushed skin. But in neuromalignant, serotonin and sympathetic overactivity, you get a diaphoretic skin. What about the bowel sounds? If you can remember, in serotonin syndrome, I have previously discussed this as well. In serotonin syndrome is very similar to that of carcinoid syndrome. So what do you get? You get diarrhea. It's because of the increased peristaltic activity. So here you get diarrhea. Serotonin syndrome, you get diarrhea. But in neuromalignant syndrome and the sympathetic system, usually the bowel sounds are normal. However, without the parasympathetic activity, will you be able to have peristalsis? No, right? So in anticholinergism, you will get absent bowel sounds. In neuromalignant syndrome, sometimes the bowel sounds can be slightly diminished, and in sympathetic overactivity, the bowel sounds can be slightly increased, but not very significant. Then what about the reflexes? The reflexes, again, you have to think now. Um, it's something like this. What happens when there is exclusive sympathetic activity? You get a uh, you get exaggerated, that's exaggerated sort of reflexes, so reflexes would be increased. And what about neuromalignant syndrome? Again, in the neuromalignant syndrome, you get so much of rigidity, it's so rigid that the patients will have reflexes. It's like Parkinsonism. So in Parkinsonism, what would you think? Even though in if it is upper motor neuron loss, of course there will be exaggerated reflexes, but this is not like that. It's because the dopamine is not acting well. Hence, what would happen is that the body is very stiff, but there is the reflexes are, there is bradyreflexia, which means the reflexes are reduced. In serotonin syndrome, it's the opposite, where you get increased reflexes, exaggerated reflexes. But what about anticholinergics? In anticholinergic system, you get now the, for the action of the muscles, reflexes happen because of the muscle activity. For the action of the muscles, the muscarinic receptors have to work through acetylcholine. Will it happen? No. So the reflexes are reduced. So SBR can be used to identify the clear-cut overdosage or the poisoning. So practically, as a medical registrar, what I do is I assess the pupils, I assess the skin, I assess the bowel sounds and the reflexes. I do a little bit of a tapping. Later on, I will ask for an ECG. And I will look at the pulse as well. So other than the vital monitoring, the next thing that I would, this is a very, I know the things are very much sophisticated than this, and also it will be extremely problematic. It's an intertwined thing that you will not get a exclusive answer. A clear-cut definition is somewhat problematic, but this is somewhat a good approach to identify what sort of a poisoning the patient has. So then I go for an ECG, and with the ECG I think about the other possibilities. Now this scenario, you will be able to identify that. Now the pupils are dilated, so we thought about either parasympathetic or sympathetic activity. However, the skin is dry and flush, so you are thinking about a loss of parasympathetic activity. Now what about the parasympathetic activity? You know, it could be an anticholinergic drug or a plant poison. So in this case, possibly the patient is having depression and was treated for urine tract infection, might be because of a urine tract infection that might have been triggered with acute urinary retention. So the patient would have probably been on TCA or quatapine. How to identify? Now then you do the ECG and see. Quatapine is a usual antipsychotic, not the usual drug that you get give in depression, but there are circumstances where you see the psychiatrist has prescribed quatapine as well. So how to go through the mechanism? Then you get the ECG done. In the ECG, now what has the question given you? The ECG shows heart rate changes, tachycardia. So now you are certain quatapine usually causes prolonged QD only, but it is again not very significant. Prolonged QT only, but there is tachycardia, and also there is a very a somewhat a characteristic phenomena called the terminal R wave. So now you are confirmed that this is a TCA poisoning, a very important one to identify. So what about TCA poisoning that you need to know? TCA has few modalities of action. One would be the action on the fast sodium channels. What would it do? The fast sodium channels are found in the CNS system and the heart. So low neuronal activity leading to drowsiness and reduced GCS. Once the GCS is reduced, there is a possibility the patient might aspirate, and it also has its implications on the respiratory system, respiratory control center, which will lead to respiratory compromisation and sometimes reduced respiratory rate, something very similar to that of morphine or opioid poisoning. But in opioid poisoning, you get pinpoint pupils rather than that of dilated pupils. So that is that. Then you get the heart. In the heart, somewhat there are few things that you need to know. The sodium channels would be, the fast sodium channels would be blocked. Therefore, what would happen to the heart? The QRS timing will be prolonged. This can be used as a subtle surrogate to identify what sort of an action TCA does as well. QRS time, if the QRS time is more than that of 100 milliseconds, you know that the TCA has started to act. So 100 milliseconds here has to act, and you have to anticipate the problems of a seizure because the central nervous system has a very low threshold. But if the QRS is more than that of 160 milliseconds, the Purkinje system is somewhat blocked. So there will be ischemia to the heart, and the ischemic potential will lead to ventricular fibrillation, a malignant sort of an arrhythmia that can lead to death instantly. So this is a possibility. Now, some characteristic feature that you would see, look at the AVR. AVR will show a terminal R wave. Terminal R wave, you can Google it, or else I can just post it in the group as well. So it's a terminal R. And you may look at the R to S ratio. This can be used as a severity identifier as well. If the R to S ratio is more than 0.8, you know that the TCA is exclusively working. So look at the QRS. QRS will be prolonged, and there is a potential that it can go to ventricular fibrillation, and AVR might show terminal R waves, and the R to S ratio will be increased as well. Right. What else? The second modality of action is a potassium channel blocker. Blockade in the potassium channel, specifically a one that is seen in the heart. So what would happen once there is low potassium? What would happen to the heart? You know, this is a fundamental rule. It will lead to prolonged QT. Prolonged QT, you get it with low magnesium, low calcium, and low potassium. So a prolonged QT would be seen. Now, if you can remember, I have taught about few other conditions, other drugs that might lead to prolonged QT. But again, you would see prolonged QT in TCA as well. What would happen to if there is prolonged QT? There is a potentiality it might lead to a susceptibility that it might lead to a tosa de pointes. So that is number 2. The third modality of action would be the alpha adrenergic block. So in this case, it would actually block the vasoconstrictability of the sympathetic system, and hence what would happen? There would be vasodilation leading to a flushed skin that is of a somewhat high temperature. So hot flushed skin. Now again, this will not be seen in sympathomimetic activity. In sympathomimetic, you get a diaphoretic skin and a cool skin rather than of a flushed hot skin. So very typical of TCA. The fourth would be GABA receptor antagonism. GABA receptor antagonism. GABA is a CNS inhibitor. Once this is antagonized, what would happen? The activity of the brain increases. So it will be consequently led to a seizure. Right. The fifth mode would be the antimuscarinic effects. So a most important one, if you see this adrenergic block with muscarinic antimuscarinic effects with cardiovascular changes, you are looking at a TCA poisoning rather than anything else. All of these three are combined to TCA rather than any other drug. So antimuscarinic effects, again, it will lead to all these loss of parasympathetic activity, primarily the loss of bowel motions, acute urinary retention, and the pupil sizes to be dilated. So all of these are antimuscarinic effects. Right. And you might also be blind temporarily because the pupils are so dilated. So that's what these terms come: blind as a bat, hot as a hare, and full as a flask, and the other things as well. So right. So these are the things that these are the symptoms that you have to look for in a TCA poisoning. So what other now? Something that has to be said with a pinch of salt is that similar action is seen by few others as well. Specifically, the cardiovascular system changes or the heart, the ECG changes can be seen with antiarrhythmic drugs of 1A and 1C class. If you can remember your pharmacology, it could be 1A means it is flecainide and propafenone, and 1A means quinidine, 1C means flecainide and propafenone. So quinidine effects. Quinidine also leads to visual disturbances and hearing loss. So that is called, if I can remember, it is called kinconism. Right. Synconism. I'm not particularly sure. It could be, it is synconism. You can go and check. Right. So TCA, that's that. And then what are the other one? The neuronal effects, the GABA activity is somewhat shown by, the CNS effects are shown by bupropion as well. So, but bupropion does not have that much of effects on the heart. HCQ, chloroquine, the anti-malarial drugs can have an effect on the potassium channels, leading to QT prolongation, but not the other things. So one way or the other, all the combo will not be shown. Important one that need to be said is the beta blockers. Beta blockers can have somewhat a similar action because it will not a similar action, but it can have an anticholinergic effect. But what would you see in beta blockers? Beta blockers, you see bradycardia, heart rate is decreased, and you would see a CBS or a blood sugar derangement. It is seen in usually hypoglycemia, reduced blood sugar. So these are some other anticholinergic effect carrying drugs, but will have somewhat differed symptoms on the patient. Right? How to treat the it? It is primarily now it is anticholinergic effect that you have to treat. How to treat is that either you give anticholinergic effect. There are two problems. One thing would be the acidemia, the acidosis. The acidosis happens because the heart is not working well and there is hyperperfusion. The lungs are not, there's respiratory compromisation. There is this hyperperfusion of muscles, so they produce lactate acid. So there is acidosis. This acidosis acts as some sort of a positive feedback to increase the effects. So acidosis itself has detrimental effects on the CNS system and the heart. So acidosis, and there is reduction of sodium. How to treat this? The sodium channel blocker. So you give sodium bicarbonate. So the answer for the question is as also this: you give sodium bicarbonate. You give repeated sodium bicarbonate until the QRS comes to a more or less of the norm value, less than that of 100. If it is refractory, then in refractory conditions there is a place for hypertonic saline. Not always, but hypertonic saline. And this is also very lipophilic drug, so you can give IV lipophilic emulsions to extract the dialysis will not prove beneficial. And if the prolonged QT is so much that you might want to give magnesium as well to stabilize the heart. One way or the other, avoid antiarrhythmics of 1A and 1C, which are quinidine and propafenone and flecainide. Because they are also in turn sodium channel blockers, which will lead to increased action. And for the respiratory system, you might need intubation or might need ECMO. Right. So if there is complication of seizures, how to manage seizures? You give diazepam or lorazepam, which is the first line drug. And if it is not working, if it is refractory, then you go for barbiturates. Sometimes even propofol for sedation. So this is the management. And as a distinction point, I would like to say sodium channel blocking in the conduction system of the heart. What is the syndrome? So you get something similar to that of a Brugada. The coved the Brugada phenotype, which is phenoscopy. In fact, it is the coved ST changes that you see in V1 and V2. So this is everything that need to be said, and sometimes it has a very rare association with Takotsubo, similar to that of sympathomimetic overactivity. So this is what you see, and I have tried to give a comprehensive account on TCA poisoning, including everything that is required. And perhaps it is not possible to question beyond this level. Right, thank you. We'll meet with the question number 10.